So we've just got a couple of minutes, and we just thought we'd just introduce some of the work of the LCA, but much more importantly, kind of ask the question with you really, how we could work best with the clerk, because we would be very keen to do so. So I'm sure everybody is aware about this, but just in case, you all know that across England, the networks for cancer have now been dissolved, and there are now these things called the Strategic Clinical Networks and the SCNs, and they are not in every disease group, but cancer is a large group. And so the London Strategic Clinical Networks for Cancer are divided into two ICSs. One is called London Cancer, and that's in North East and North Central London. And then the London Cancer Alliance covers North West London and all of South London. So it's the kind of crescent around London, and then the blob at the middle and top is London Cancer. And the integrated cancer systems in London were set up earlier than the strategic clinical networks for the rest of England, which were set up, as you know, at the end of 2013. So the London Cancer Alliance's key objectives are to reduce unwanted variation in treatment, in diagnosis, treatment, care, outcomes and experience across London, to improve early diagnosis of cancer and clinical outcomes, and to enhance patients' and carers' experience and quality of life. And as you will know, there's a way to go there in London. Obviously, it's key that we deliver equitable world-class cancer care, and the reason for the integrated cancer systems coming into being was the often spoken experience of the patient and their carers, that particularly in London, there are some very complex pathways for them to navigate. And so if you look at the National Cancer Patient Experience Survey, the worst findings are in London. And if you look at the 8,500 free text comments that patients wrote last year, and we're just analysing the free text for this year, very high up in the 3,500 comments about improvement comes the difficulty of navigating such complex pathways. So one of the reasons for the integrated cancer system was to join providers up, so that hopefully by joining providers up and ensuring seamless pathways of care, very easy to say, quite difficult to operationalise, and the cancer patients are testament to that. It is important that it's the whole cancer pathway, and so it is importantly, right from its inset, has included specialist palliative care and end-of-life care. The clerk, several of us in the London Cancer Alliance have worked with one of the clerks in London, and we feel it's an incredibly important relationship if we are able to work together. We've really, in the last 2 years, been setting up and looking at a lot of the commissioning and operationalising of cancer care, including early diagnosis and treatment, and have really not yet started on major research work. But we are just about to do that. So the advert has just gone out for the London Cancer Alliance Research and Development Director, who will work across a population of 5.4 million. So it is a wonderful area to harness research. And as you know, we have the Institute of Cancer Research and 2 academic health science centres and 2 clerks in the LCA. So there's a lot of potential. So in April the 23rd, I think, we interview for the R&D director, and we have Dame Sally Davis and co coming to interview with us. So I'm very much hoping that we will be able to appoint and establish a research board, and then we'd be hugely grateful if we could, then you might feel that we could work with you. The key, I think, is that we want to look at the whole pathway of research. So in the advert, it is not just about cellular research and basic science. It is right through to health services research, and also to capture the whole of the cancer patient journey. So really, I think that's most of what I want to say, and then I'm going to hand over to the palliative specialist, Maureen.
So the palliative care group was formed about a year after the initial work around the LCA. So it started to pull together in January to March 2012, and essentially has been pulled together to improve access, experience and outcomes for patients requiring either specialist palliative care or end-of-life care, irrespective of diagnosis, which of course is a tension for a group within the London Cancer Alliance, but we acknowledge that palliative care has an important remit to look across all diagnostic areas. But we're looking at this across this LCA population. And the membership of the group is multidisciplinary. We have carer representatives on board, and we have representatives from primary, secondary, tertiary providers. The NHS and voluntary sector hospices are included, and we are lucky to have FLIS on the group as well, with a CLAHRC perspective, amongst other of her many bows. In terms of what common goals the palliative care group within the LCA have, and this has come directly from Dr. Nigel Sykes, who's the chair of the group, who couldn't be with us today. We're very clear that the outcomes measurement, as FLIS has mentioned very clearly earlier, is a very important area of work that the palliative care group are concerned about. We did a survey in 2012 across all of the specialist palliative care services, and following the findings from that, we have it's a concern that we want to improve the equity of access and the standards of specialist palliative care services across the whole of our area. Our survey showed a need for more unified and regular use of appropriate outcome measurements, so that it's not just happening on an ad hoc basis, it is a consistent, regular outcome measurement that we're gathering. And in terms of actually working on clinical outcomes for palliative care, we would be very keen to work closely with the CLAHRC in terms of taking this work forward. Another area that we are very keen to look at is actually what we are doing in terms of education and training to make some of this a reality. And there has been, and there is currently, a group that we've been meeting and that Shelley has been chairing, that is actually working across the health education boards, the academic health science networks, and the CLAHRC FLIS is on that as well. And we have many emerging pan-London end-of-life care networks that we really need to communicate with effectively to ensure that we can actually take this clear education and training strategy forward, to have an outcome that will ensure that all relevant providers, whether specialist palliative care, whether end-of-life care, and whatever care setting they are in, we have competent and confident staff in place across all the different settings to ensure provision of high quality care. We have a greatly challenging new landscape, with many different bodies forming with their remit not maybe as clear as we would like it. But what we want to do, the palliative care group at the LCA, want to be able to work with the CLAHRC, with all of these bodies, to really try and take things forward. Essentially really trying. One of the things I think that was mentioned about the issue of the non-specialist palliative care is that as part of the LCA, we do have access to specialists, again, I know Catherine, but the non-specialist palliative care clinicians that we could try and influence to try and take that forward. And I do think that that's something that we can contribute, access to those cancer clinicians beyond specialist palliative care, to try and improve things and take things forward.